Right, today I'd like to take you through examination of the foot and the ankle. Whenever you're starting an examination, you should have taken a good history prior to the examination in order to give you some idea of what the problem is. That may actually tell you that you're looking more for a systemic problem, such as rheumatoid disease or gout, or is the pain in the foot or the ankle radiated from elsewhere, such as coming from the back. What you should also do is examine the patient's footwear, looking at the soles. This is much better if your patient has got footwear that they've been using for some time. These are quite new, I believe, so it's not telling us a great deal. What we want to do is to actually, first of all, inspect. And we're looking at the patient from the side, the front, and from the back. And we've got to think that there are obviously two sides, and we're looking at the lateral border, and then we're looking at the medial border of the foot. Make sure that you've exposed your patient adequately in the respect that you want them to take both shoes and socks off, and ideally they're exposed to the knee or just above the knee. You're looking for any malalignment, and you're looking at the arch in weight bearing, and you're looking at the axis of the foot. Is it pronated or supinated? From behind, you'll be looking for things like a Haglund deformity, which I'll come on to later. And you're looking to see if there's any swelling or erythema there. Are there any scars from previous operations? Are there things like fat necrosis from steroid injections, either into the joints of the foot or into the ankle? When we're looking at the toes, we look at the big toe to start off with, and you're looking for conditions such as hallux valgus, hallux limitus, or hallux rigidus. And the test for the hallux limitus and valgus is you try and pull the big toe upwards, and if it won't go past the neutral, then that's a hallux rigidus, and we'll come on to the range of movement later on of the big toe. You're looking also for hammer toe, claw toe, or mallet toes. There is a test called a Jack's test, where you do that lifting of the big toe, and that should reconstitute the medial arch. Talking of the arch, you're looking to see, is it a normal arch, or is there some degree of pes planus or pes cavus? If it's pes cavus, you're thinking of a neurological cause, perhaps, and you must do a full neurological examination. Just turn you around a wee bit, Mark. We're looking at the Achilles tendons. Compare the two. You're looking to see if there is any thickening there or any swelling there. There should be approximately 5 degrees of valgus angulation at the heel. And you can see this quite nicely here with Mark. If we just get him to go up on tiptoes, just both tiptoes, and that valgus angulation should become a varus angulation. Okay, relax again. We're also looking at the calf muscle bulk, and you may see some wasting here. This can be following an injury to the calf, it can be after surgery or immobilization of the foot or the ankle, or it can be due to a neurological cause. We're now going to see Mark walk. What we're looking for here is, what's the gait like? What you're looking for is, you should see a good heel to toe strike. Is there any asymmetry? Is the gait antalgic? You're looking at the foot progression angle. The foot progression angle is the angle the foot makes with an imaginary line drawn between the legs. You're also looking to see whether or not there's more than 1.5 to 2 toes visible laterally as the patient walks. If there is, then that means that the foot is externally rotated, or it can be due to some chronic posterior tibial tendon problems, resulting in collapse of the medial arch. Can we just see you walk now, Mark? Okay, and back this way. Okay, and we can see that on the right side there are more than 1.5 to 2 toes. Just go once more. Okay, and come back. Okay, that's fine, so that'll be fine. What we're then going to do in a standing position is to look at stability. What we're going to do now is get the patient stand on one leg, so bend up one knee. Okay, and that's with the eyes open, and now with the eyes closed. And you'll do that on both sides. Could also go on and do some other proprioceptive checks, but that's going to take some time, and that's out of the range of this particular video. We're now going to put Mark on the couch. I like to do a lot of the examination of the foot and ankle sitting in a sitting position rather than laying on the couch. Once again, what we're looking for here, we're looking at the arch of the foot, only now in non-weight bearing. We're going to look at the soles of the feet to see if there's any callus on the feet. Now, you should bear weight on the first and fifth metatarsals. So if there is any callus in the 2, 3, or 4, then that means that the loading here is abnormal. You're looking between the toes to see if there is any signs of infection, such as athlete's foot, that may well pick up just on the 4-5 interspace there. Or occasionally you'll even see things like melanomas here that are hidden. We're going to palpate on the base of the foot here, just at the anterior aspect of the calcaneus, where the plantar fascia comes in. And plantar fasciitis, the patient will notice a lot of tenderness in here. Any problem? No. We're also going to feel the temperature and use the back of your hand to do this. And if there's an increase in temperature, that could be infection or an inflammatory response. You may want to look at effusion, and you may be able to flush effusion from the medial and the lateral gutters. You're then going to palpate the arteries to see what the circulation is, and there's the dorsalis pedis artery that you want to feel for, and the posterior tibial. Get your patient to pull their foot up and pull the big toe up at the same time, and you'll see the tibialis anterior activate and the extensor hallucis activate, and in that little triangle between the two is where the navicular is. It's called the end spot. And palpation in the end spot may show up if the patient has a stress fracture of the navicular. Other stress fractures in the foot, in the metatarsals, the common ones affected are the second and third metatarsals. So palpate this area too. We're now going on to sensation. What we're looking for are the 5 nerves that supply the foot. There's the tibial nerve, and you test by just touch. Just let me know if you can feel this. The tibial nerve supplies the sole of the foot. There's the superficial peroneal nerve that supplies the dorsum of the foot, and you just ask the patient if they can feel. There's the deep peroneal nerve that supplies the first web space. There's the saphenous nerve that supplies the medial border of the foot, and the sural nerve that supplies the lateral border of the foot. So we just test the sensation there and do the same on both sides. We're then looking at the ankle joint itself. The most common injury of the ankle is the anterior talofibular ligament sprain. Approximately 17% of football injuries actually involve the ankle, which is a similar number to the knee. What we're going to do is I'm going to try and show there's 5 ligaments that we're concerned about really around the ankle. Just pop your foot into a neutral position. And the anterior talofibular ligament runs across the front here. Then there's the calcaneofibular ligament that runs more in the middle here. The posterior talofibular ligament then runs at the back here. We're then coming to the front of the ankle, and we're looking at the anterior inferior tibiofibular ligament that runs across here where my thumb is, and the deltoid ligament is also called the medial ligament, runs up this side here. When you've got acute trauma and the ankle is really very swollen, you've got to think sometimes just outside of this area because there are other things that can be affected. And there is a fracture around here that's called the meson nerve fracture, which is a medial malleolar fracture, a distal tibiofibular syndesmosis and interosseous membrane rupture, and also a spiral fracture of the proximal third of the fibula. So if you're only looking at this big swollen ankle, you'll then miss the fact that there's a fracture higher up also. And the patient may be distracted away from this area by the pain in the ankle. We ought to talk also about, if you're in the emergency department or also in general practice, what's called the Ottawa rules for X-raying ankles. And the Ottawa rule for the ankle is any pain in the malleolar region and any one of the following, which is tenderness over the distal 6 centimetres, the posterior border of the fibula, or lateral malleolar tip tenderness. Tenderness over the posterior border of the distal 6 centimetres of the tibia, or medial malleolar tip tenderness, or the inability to weight bear both immediately and in the emergency department more than 4 steps. There are also Ottawa rules for the foot, which is any pain in the midfoot and one of the following, which is bony tenderness at the base of the 5th metatarsal, bony tenderness of the navicular, and we talked about the end point previously, and the inability to weight bear, once again, both at the scene of the incident and in the emergency department, more than 4 steps. What we're also going to do is to look at the medial and the lateral aspects of the ankle, just in palpation. And the tendons on the medial side, I like to think of as Tom, Dick and Harry, which are tibialis posterior, D is flexor digitorum, and H is flexor hallucis longus. Really got that one wrong. And on the lateral side, feel for the peroneal tendons. You can get subluxation of the peroneal tendons over the lateral malleolus, and the patient often will present with either a click or a painful click on the lateral aspect. And then you'd also want to think about a tarsal tunnel syndrome, and tarsal tunnel syndrome will often give you a positive, what's called a Tinel sign, where you tap on the area of the tibial nerve and ask the patient if they feel like pins and needles or an electric shock going into their foot. Okay, we now go to range of movement of the ankle. It's important that you get your patient to move their ankle themselves and also to examine passive movements, and you compare the two sides. Now, if you can just pull your foot upwards and push right down, that's dorsiflexion, that's plantar flexion. Then I tell the patient to try and put your soles of your feet together, and that's inversion, and then out the other way, and that's eversion. And you can compare the two sides. We then want to do that with passive movements, and one of the reasons for that is because that may give you pain at end of range when you're stressing it. Any problem?
No.
Any problem? No. If you get pain when you're pushing right down, the patient says they get pain at the back of the ankle, that can be due to an os trigonum, an inflammation in that area. If they get pain when you push the foot right up, that can be due to either a synovitis or a footballer's ankle, which is due to osteophytes forming on the distal aspect of the anterior tibia or on the anterior aspect there of the talus. Range of movements are plantar flexion should be 0 to 50 approximately, dorsiflexion 0 to 20 degrees, inversion should be 0 to 35, and eversion 0 to 25. Movement of the toes then, they should extend, the toe extension should be to approximately 80 degrees, and toe flexion should be around 30 degrees. We're then going to test strength, so you get your patient to pull up and push down, pull inwards and push outwards, and then the same with the toes as well. Right, we'd like to go to some specific tests now, and there's a test called the squeeze test, looking for what's called a Morton's neuroma. And Morton's neuroma is a small nodule on the nerve, the interdigital nerve that runs between the metatarsal heads. You may find there's tenderness over the dorsum, and these neuromas are commonest between the second and third and fourth toes. And the squeeze test, I tend to put my hands together and clasp them, and then squeeze across the metatarsals there, and you should either feel or hear a click, which is painful. And that's called a Mulder's click. If we think about the actual foot itself and how it's split into the various sections, the hind foot is the calcaneus and talus, the midfoot is the navicular bone medially, the 3 cuneiforms and the cuboid laterally, and then the forefoot are the metatarsals and the phalanges. There's an injury that can occur called a Lis-Franck injury, which is a tear of the Lis-Franck ligament that runs between the medial cuneiform and the medial surface of the second metatarsal. And there are two bands, one on the dorsum and one on the plantar aspect. These injuries are often missed and can give quite significant disability if you do miss it. History may be important also, but we'll not go into that today. Signs of a Lis-Franck injury can be bruising on the sole of the foot, and if you fail to look at that, at the sole of the foot, you're going to miss that. The other is what's called a piano sign, which you can also have with shoulder injuries and wrist injuries, so don't get confused. And basically that is fixing the midfoot and putting the first and second metatarsals into extension and flexion, abduction and adduction. So you're doing this movement, this movement, this movement, and this movement with the first and second metatarsals, and that's called a piano sign. Okay, now I'd like to go on to the ligament tests. We were saying before there are 5 ligaments, and the testing is, the first one is called the Taylor tilt test. And what we're doing with that is to stress the various ligaments on the outside of the ankle. Now, what we're trying to do is to isolate these ligaments. And if you want to try and isolate the anterior talofibular ligament, which is the one at the front here, put the patient into plantar flexion, then grasp the calcaneus, stabilize the tibia and the fibula, and you go into inversion. And you ask your patient, is that painful? And if you've got a tear in that ligament, that's going to be painful. The only ones that may not be painful when that happens is if you've got a complete rupture of these ligaments, and that movement then is not actually stressing a ligament at all because none of it is left. You may get some discomfort from other areas, but don't be confused that you've got a patient with a big swollen ankle, and when you do that, it's not painful not particularly painful for them. So that's the anterior talofibular ligament in plantar flexion. Then you're moving to the calcaneofibular ligament, which is this middle one on the lateral aspect, and put the patient's foot into neutral. Grasp again the tibia and the fibula to stabilize, and then invert again. Any problem? And then finally, for the posterior talofibular ligament, which is the one at the back here, what I find useful is to almost cradle the foot and support the foot with your forearm, and your forearm can then put the ankle into dorsiflexion and then invert again. You're not going to get too much movement on this one actually, but you're looking to see if that is painful, and the pain should be at the back of the ankle. When you're looking at the medial side or the anterior inferior tibiofibular ligament, there's 2 tests that have names, and they're called the Kliger test or the ER test. And the difference just depends on where you grasp the foot. The Kliger test is looking with a patient in a neutral position, and you're everting the ankle. Any problem? If you're doing it the ER test way, you're doing the same movement, but you just grasp the calcaneus and you're coming over. No problem. That's the medial ligament. If you're testing the anterior inferior tibiofibular ligament, what you then do is to grasp again, put the patient up into dorsiflexion, which may itself be painful because that movement is separating the tibia and the fibula at that inferior tibiofibular joint. And once again, you then put the patient into eversion, and also I find a little bit of lateral rotation, and if that's painful, they'll get the pain up here. Now, this injury can be quite a nasty one, and it can involve the interosseous membrane also, and there is a test called the squeeze test to see how high this injury goes, and basically you're squeezing the tibia and the fibula together. So if you get pain when you're squeezing just up here, and the pain is coming right up the shin, that's a nasty injury. And if it doesn't happen until you get right down here, then the injury is a lower injury. Then I'd like to show you just the final test in this position called the anterior draw test. And the anterior draw test is seeing if you can get displacement of the of the talus coming forwards. So you fix the tibia and the fibula, grasp the calcaneus, and then you're pulling forwards. And any movement more than 5 millimeters is abnormal. Now, some people find it difficult to do that test in this position. So I'd just like to show you a different position to do this test in. Okay. The other way to do this test is get the patient to lie on the couch, and you're putting the foot into some plantar flexion. Grasp the foot, and instead of pulling the foot forward, you're pushing the tibia and the fibula backwards. And what you're looking for is there movement of the tibia and fibula backwards rather than looking for the movement of the foot forwards. And I find that that's a good way of checking instability here. And there's very little movement there at all. And then you compare the two sides. I'd now like to do some examination just in a prone position. Right, I'd like to just show you a couple of final tests in a prone position. What we're doing when we're in this position is having a look for what's called the Haglund deformity, which we mentioned briefly earlier on, which is a bony deformity on the back of the calcaneus. It's also called the pump bump. Heredity plays a part in this, as does high arches, tight Achilles tendon, tight soleus and gastrocnemius muscles. When you're examining the shoe wear, you may have found that there is excessive lateral wear on the shoe with this condition. I'd like to show you a couple of tests now for Achilles tendon problems. One is called the Thompson test. And the Thompson test is looking for Achilles tendon rupture. What you do is get your patient to lie prone, flex the knee to 90 degrees, and then squeeze the calf. And if you just look here at the angle of the foot, when you squeeze the calf normally, you should get some plantar flexion of the foot. If you get no movement at all, that's likely to be a ruptured Achilles tendon, and that's then called a positive Thompson test. Another test is called the Royal London test, where you're looking for Achilles tendonitis. And what you do with that is you come down on the Achilles tendon and you find the point that's painful. And then if that point is painful, you then get the patient to dorsiflex the foot, pull your toes up towards you, and the area of tenderness should move, and it will move downwards. If the area of tenderness doesn't move, and it's still sore in the same spot, then the likelihood is that that is the paratenon that's inflamed rather than the Achilles tendon itself. You'd also palpate down to see if you can feel any nodules or any dips or defects there in the Achilles tendon. The last thing to look at is the subtalar joint, and I find this better doing this in this position, and flexion of the knee to 90 degrees, and then I cup the calcaneus and then roll it medially and laterally. And you should feel approximately 5 degrees of movement each way. And that completes the examination of the foot and the ankle. Thank you very much.